What's the matter?
I have a headache.
It might be a tumor.
It's not a tumor. It's not a tumor at all.
Actually, Arnold, it may be a tumor. Hello, everyone. Today, I will be presenting on pituitary adenomas. As we all know, the pituitary gland sits in the sella turcica, right below the optic chiasm, where it churns out hormones that we need to grow and survive. Among these hormones are growth hormone, prolactin, adrenocorticotropin hormone, or ACTH, thyroid stimulating hormone, or TSH, follicle stimulating hormone, or FSH, luteinizing hormone, LH, melanocyte stimulating hormone, antidiuretic hormone, or ADH, and oxytocin. Well, that was a mouthful, but thankfully you'll never have to listen to me utter that string of words again. Anyway, you see why the pituitary gland is so important to us. These hormones affect virtually every organ in the body. That's why when things go wrong there, they do have a tendency to go wrong everywhere. Pituitary tumors come in a few different flavors. There are secreting tumors that produce an excess of some of the aforementioned hormones. There are non-secreting tumors that just sit there and take up space, or they could hemorrhage. That's called a pituitary infarction. And then there are those tumors that just reduce secretions from baseline. So, how on earth do you get a pituitary tumor? Well, the answer is, we don't really know. We do know that some tumors are genetic, but most just seem to be plain bad luck. So, how do you know if you have a tumor? Well, apart from having an MRI or CT done, there are several symptoms that you could present with. As Mr. Schwarzenegger showed us earlier, headache is a common symptom. This can occur along with nausea, vomiting, fatigue, low blood pressure, body hair loss, unintended weight loss or gain, and the most relevant for us is vision loss. The vision loss presents mainly as a bitemporal hemianopsia if there are any visual symptoms at all. For secreting tumor, the list of symptoms increases depending on which hormone is stimulated. For ACTH secreting tumors, you will notice all the signs of Cushing syndrome, because you'll have it. With growth hormone secreting tumors, you have your acromegaly in adults and gigantism in children, along with excessive sweating, high blood pressure, arthritis, and misaligned teeth. A prolactin secreting tumor causes a decrease in normal levels of sex hormones and can cause differing things in men and women. In women, it causes amenorrhea and galactorrhea. In men, it causes erectile dysfunction, gynecomastia, and infertility. Another type of secreting tumor is the TSH secreting tumor. It pumps up your body's metabolism. This can cause weight loss, irregular heartbeat, and irritability. Tumors that decrease secretions cause hypopituitarism. This is characterized by another laundry list of symptoms that range from loss of appetite, headaches, and constipation, to infertility, loss of sex drive, and excess urination. Non-secreting tumors are a whole new monster. While having no effect on hormone secretions, it can still cause damage in the brain by growing and compressing other tissues. It is usually caught only after it has reached a considerable size because of its relative lack of symptoms. Pituitary tumors can compress several cranial nerves. Cranial nerves 3, 4, 5, and 6 can all be compressed. When this happens, signs and symptoms like ptosis and diplopia can show up. Among the various cranial nerves that can be compressed, the one that produces the most shocking symptoms is the optic nerve. It results in a progressive vision loss leading to a bitemporal hemianopsia. If the headaches don't tip the patient off that something is wrong, losing about half their visual field is sure to wake them up and show them the severity of their problem. Diagnosing pituitary adenomas can be done in several ways. A CT or MRI is going to be your best friend. They will be able to show you if there's a mass or not. Endocrine, blood, and urine testing can check to see if it is a secretory or inhibitory tumor. Vision testing can also be helpful in the diagnosis of a pituitary tumor. Now that we have diagnosed a pituitary tumor, what do we do about it? Well, one option is to have it cut out. You could either come in through the sphenoid via the nose, or you can go through the upper cranium, which is better for large, more complicated tumors. Surgery is by far the best approach if the tumor is pressing on the optic nerve. Another option is radiation. Radiation can be used in conjunction with surgery, or by itself. Like surgery, there are also two forms of radiation therapy. external beam radiation, which can take years to control the tumor, and stereotactic radiosurgery, which uses focused beams of radiation that are the exact size and shape of the tumor. Like external beam radiation, stereotactic radiosurgery can take months to years to see an effect, but it causes less damage to adjacent tissue than external beam radiation. Both of these procedures are not to be used if the tumor is close to sensitive structures, like the optic nerve. Medications are used to block excess hormone secretions in secretory tumors, provide extra hormones in inhibitory tumors, and can also shrink some other tumors. In fact, the medications to treat a prolactin-secreting tumor, Parladel and Dostanex, are so effective that surgery may not even be necessary. If a patient has a tumor that isn't causing any signs or symptoms, you may defer therapy and just wait it out. There's always a chance that nothing will ever happen, but you must always be prepared for the worst. In summary, there are several types of pituitary tumors, each causing a plethora of different symptoms. We should always be watchful for any changes in a patient's visual field, in addition to any of the other symptoms that go along with pituitary tumors. If you suspect that your patient might have a pituitary adenoma, go ahead and send him or her off for an MRI or CT. Better safe than sorry. Thank you.